Thank you very much. Good day to you all. Thank you very much, Dr. Spanda, for the kind introduction. I want to welcome you all to Bulawayo. For those who don't come from Bulawayo, I actually come from Bulawayo. This is my hometown. This is what we call the city of kings and queens. So we don't behave like Hararians. Our roads are wide. We are not in a rush. We behave like kings and queens. I want to thank the organizers for this conference for allowing me this opportunity to present. So I'm gonna like to acknowledge a few individuals. The breast multidisciplinary team meeting that I work with, all my breast patients that I see. I work with a whole team of doctors, oncologists, radiologists, breast nurses, physiotherapists, and other colleagues, surgeons like Mr. Magara. The ABS, the Association of Breast Surgery, the Royal College of Surgeons of England, that made it possible for me to have the fellowship in breast surgery. I would also want to acknowledge Mr. Magara, my colleague, and it was a wonderful presentation. I didn't think about the bras, Dr. Spanda. And I also want to acknowledge my mentor, Professor Muguti. I'm going to talk about briefly about breast cancer treatment and the updates there. One of the most important things to understand is the understanding of the tumor biology, that we have moved on. We no longer just talk about breast cancer being invasive ductal cancer or lobular cancer. We have moved on to actually knowing better information in terms of the tumor biology. We now know about receptors, we now know about Ki67, whether the grade of the tumor, and also for those other subtype of patients, we actually do something called oncotype DX. So all this is in the understanding of the tumor biology and how to actually best treat it. So because of that, things have totally changed in breast cancer management. It's not an easy equation. It's quite complicated, and it's not one size fits all. There's advancement in radiology, diagnostic and localization capabilities. So long back, during Professor Mguti's time, they used to put wires in the breast, and the woman will have a wire for localization of any impalpable breast lesion. Gone are those days now. I'm going to show you some examples. Of course, our colleagues, the oncologists, will tell you about the new chemotherapy agents that they are now using for better outcome. Multidisciplinary approach. So breast cancer treatment now is no longer a one-man show. It's not about what I think for the patient, but it's about what the whole breast multidisciplinary team thinks about what's the best options for the patient. And it is these options that we then give to the patient, and then we offer an individualized care, patient-centered approach where the patient is involved in the decision-making process. So we give them the options that are available for them, and then they decide what they prefer. And then I'm going to talk about some fancy gadgets and technology that we are now doing in breast. So I'm not going to discuss much about the axilla today, if that's okay. So I'm just going to limit myself only to breast surgery. But however, for the axilla, less is more. So now we tend to do more of sentinel node biopsies instead of axillary clearance. It's not all patients who come with involved nodes who have been diagnosed with breast cancer that will actually require axillary clearance. I can actually give you a very good example. Just this morning, I did a case at Gweru Provincial Hospital. 35-year-old lady with a 2-centimeter cancer in her right breast, which was confirmed to be a grade 1 invasive ductal carcinoma with no lymphovascular invasion. This lady had noticed this lump over a few months. Imaging, an ultrasound scan, a CT scan confirmed the lump, did not show any evidence of metastasis, and at the same time, it actually confirmed that the axilla was clear of any affected nodes. But this patient was booked up for a modified radical mastectomy. And I told the surgeons, well, I don't think this patient needs a modified radical mastectomy. She needs a mastectomy, but plus a sentinel node biopsy. Because her axilla is clear. Why do you want to remove all the 25 nodes? And then you tell her, well done. All the 25 nodes are clear. Well, if she's clever, she'll be asking you, Chiremba, if they were clear, why did you remove them in the first place? So I actually did a sentinel node biopsy with them this morning, 6:30, using methylene blue that you guys use, gynaes. Good old gynaes. We always follow gynaes. So I used methylene blue and we picked up the sentinel nodes. So I'm going to talk about the principles in terms of surgery in the breast. So the decisions are actually more important than the incisions that we make, you know. And our principal goal is to have oncologically free, the cancer-free treatment. Then the aesthetic aspect is secondary. We also want to minimize post-operative complications. And lo and behold, most of my cases now are day cases. Even a mastectomy or with axillary clearance, I give patients the options of going home with the drain. We have certain ways of giving analgesia, something called PEC block 1, 2, where we give local anesthetic under the muscle, the PEC major and PEC minor, and sometimes the serratus, so the patient won't be in pain at all. If the patient is happy having the drain at home, if they're happy at managing it, they can go home the same day. So from last year, my patients come early in the morning at 6, they have their surgery at 8. If they want to go home after lunch, they do go home. They're stable. For those patients who are local. Is breast conservation surgery safe? It is. I'll refer you to those studies. Sorry. So breast cancer conservation surgery, breast conservation surgery is actually safe. I will refer you to those 6 randomized control trials that actually confirmed that when one has a lumpectomy, if they are confirmed to have breast cancer, if they get a lumpectomy with radiotherapy, so that's breast conservation therapy, the outcome is the same with a mastectomy. That's been proven. I normally keep this slide for my colleagues, the general surgeons, because as far as they're concerned, they're wondering, what am I and Mr. Magara talking about? They've been operating on the breast for years, and there's nothing new. Well, that's atlas is what can be done on the breast that the general surgeons have no clue about. Because things have moved on. It's no longer, you know, years back we used to have a businessman who used to say, Munuese. So we used to have every breast cancer patient equals to modified radical mastectomy. Breast cancer diagnosis, modified radical mastectomy. It doesn't matter whatever stage. As long as it's breast cancer diagnosis, they'll be offering you modified radical mastectomy. And that's not correct, entirely correct. For some patients, it's still indicated to have modified radical mastectomy. In fact, Mr. Magara actually questions why we should be saying the term modified radical mastectomy, because we need to be clear on what we are doing. We can have a mastectomy, axillary clearance, mastectomy, axillary dissection, or sentinel node biopsy. I'm going to discuss a few cases. So this lady had a cancer there. 70-year-old Caucasian lady, picked up on mammogram. She actually had the lump, but it was also confirmed on mammogram. And she didn't want a mastectomy. She wanted a lumpectomy with sentinel node biopsy because her axilla, the ultrasound was clear. So she wasn't a candidate for a modified radical mastectomy. is the same picture with the patient that I saw yesterday in Guero Provincial Hospital. This patient had a 2-centimeter cancer. The axilla is clear. She's not stage 4. We do get stage 4, stage 3 disease, but not all of our patients present with stage 4, stage 3 disease. So this lady opted for a lumpectomy, and that's the lumpectomy. And we do intraoperative reporting with the help of breast radiologists. So that's the area that's been removed. Yeah, and then we do extra shave if we are worried that we may be too close to the lesion. And we do sentinel node biopsy with the latest gadget called Sentimag. This is what is used in the US, it's used in the UK, Australia. We use it in Zimbabwe, believe it or not. It is in limited places, but we actually use it. So some of my patients who have relatives outside the country, we actually emphasize to them that we're actually not joking. We actually have this technology. Patients travel to South Africa for this technology, but they don't have to. And that's how she looks after the surgery. The lumpectomy is actually on the right side. And this is before radiotherapy, and this is after radiotherapy. This is a confusing picture because I was asked to submit this presentation beforehand. So just to make sure that the organizers don't understand what I will be talking about, I just mixed up the photos. So I will explain. So this lady, she's 40. She had an impalpable lesion. This area was picked up on mammogram to be suspicious. So she had a biopsy, which showed that it was a radial scar. So what we did, we put in a mag seed. I don't know if you can actually see it. That's a mag seed there. It's like a tiny grain of rice. So we don't put wires anymore. So we put in a mag seed in the area with the help of the radiologists. And then we took it to theater. We did a wide local excision with the help of the probe, like the one that I was using in the previous picture. That same probe that we use for the mag trace to identify the sentinel nodes is the same probe. This one is the same probe that we use to pick up that mag seed. And then we remove the area. So we've actually removed the area with the mag seed there. So she didn't need to have a wire, walking around with a wire, you know. And that's how she looks after the operation. She then needed a sentinel node biopsy because they found out she had a cancer there in the area that we had removed. And we did with methylene blue. So I actually invited one of the surgeons in theater to show them how simple sentinel node biopsy can be done with the methylene blue. Not necessarily for those who can make trace. If they can't afford the make trace, we can actually use methylene blue. So today at Guero Provincial Hospital, I just used methylene blue. And it just looked as blue. Even, I'm told men are colorblind. But the surgeons this morning actually believe that it's actually entirely blue. You know, and that's how she is there. This lady had a cancer there, close to the nipple on the right breast, 1 centimeter cancer. She had an option of having a lumpectomy, but she would need radiotherapy. Or she could have a mastectomy. If the nodes are clear, sentinel nodes biopsy is clear, then she will actually potentially avoid radiotherapy. So she preferred to have a mastectomy because she was worried that she may not have access to radiotherapy. But because she's double D capsize and she's got ptosis, we actually offered her what we call a Goldilocks mastectomy. We remove the breast tissue, we deepthelize lower half, we remove the breast tissue, and then we use lower half to make another breast mound. And that's how she looks. So if she puts on her clothes, you can't even tell which side was operated on. You know, when she goes back to work, people will be looking with the side, Rajona. But for her, they can't tell. It's a Goldilocks from the movie Goldilocks. You know, Goldilocks didn't know what they wanted, neither hot or cold. So she doesn't want a flat chest, but at the same time she doesn't want reconstruction with implants. So in between. So that's how she looks there. We also did a sentinel node biopsy on her using the methylene blue. This lady is 70 years of age. She had a cancer on the right breast, which was covering over an area of 6 to 7 centimeters. She has C-cup breast size. This lady didn't want a mastectomy. She wanted a lumpectomy. She has kids in the US, another one in the UK who's a lawyer, a bit cheeky, and but this mom didn't want to have mastectomy, so she went around town to look for someone who could offer her a lumpectomy. But most clinicians who saw it told her, well, if we remove this whole area for you with clear margin, there'll be a huge defect such that the breast won't look nice, so you are better off with a mastectomy. So you can actually see on mammogram, that's the area of concern. So what we then did was we removed the disease for her, we identified the perforators, and then what we then did was we did a local flap. So tissue from her lateral aspect of the breast, that's a local flap that we raised to fill in that defect. So we actually removed the whole disease, you can see there. We actually took some more down to the pectoralis fascia. And then we raised the flap. That's raising the flap, and then we fill in the gap with the flap. The defect, we fill it with the flap. And the incision is just on the lateral aspect. And that's how she looks post-operatively. So it's local perforator flap reconstruction in partial breast reconstruction. This lady had a 1 centimeter cancer. What we offered her was something called a nipple or skin sparing mastectomy. So we removed the whole breast disc under the skin and we preserved the nipple and the skin. And then we put an implant. So what she has there is the cancer there. This is after the operation. The operation is done through that incision on the lateral aspect. We have a separate incision in the armpit for the sentinel node. We're using the methylene blue. And then that's what you see there. That's the pocket now without the breast tissue. And then we put the implant. And then that's how she looked. In her case, we had to put an expander initially. But because it's an expander, we were supposed to put a permanent implant with a mesh, but she couldn't at that moment get the mesh, so we had then temporarily put an expander. Unfortunately, an expander makes lots of pressure necrosis, so after about 6 months, she had to lose that expander, unfortunately. But the plan was to keep that and then actually put the permanent implant and the mesh. This lady had a cancer, 2 areas there with the cancer in the left breast, and she wanted a double mastectomy with immediate reconstruction. And that's what we offered her. So what you actually see there is we actually did a mastectomy, but in this case we did a skin-reducing mastectomy, and then we put the implant, that's the permanent implant with the mesh, the one that I was talking about that we couldn't get for the previous patient. So we then had to put the implant with the mesh above the muscle. So there's an option of not putting the implant below the muscle, the pec major. You can actually put it pre-pectoral, and then you have the mesh. Yeah? And that's how she looks after the operation. She didn't want the nipples preserved. So we took out the nipples. She's actually 70. So she woke up with new boobs. Thank you very much.